Chapter 21. This image shows the thoracic cavity separated into the right and left pleural cavities, or fluid-filled spaces that surround the lungs. We will talk more about the pleural spaces in another chapter, so don't worry about that right now. More importantly to this chapter is the mediastinum. This is the portion of the thoracic cavity which contains the heart. The heart is surrounded by three membranes. One, the outermost membrane, or the fibrous pericardium, which forms a loose-fitting sac around the heart. Two, the middle layer, or the parietal pericardium, which is a serous membrane that lines the outermost fibrous layer. Three, and finally, the innermost layer, known as the epicardium or visceral layer, which is also a serous membrane that is located on the surface of the heart muscle. The serous fluid between the parietal and visceral layers prevents friction when the heart beats. Please watch this video. Corrigan pulse, forceful palpated pulse that collapses quickly, colchicine, severe. Corticosteroids, if NSAID is not effective. Pericardial friction rub sound. To simulate the sound of a pericardial friction rub, hold the diaphragm of a stethoscope against the palm of one hand. Listen through the stethoscope as you rub the index finger of the opposite hand over the knuckles of the hand holding the diaphragm. This sound is similar to a pericardial friction rub. Pathophysiology pericarditis is an acute or chronic inflammation of the pericardium that usually resolved in 4-6 weeks but can become chronic and last up to 4 months. It can also reoccur at any time. This inflammation creates a problem for the heart as it tries to expand and fill, and ventricular filling is reduced, which leads to decreased cardiac output and blood pressure. Etiology: the cause may be unknown or due to infections, for example, viruses, bacteria, fungi, or Lyme disease, Dressler syndrome, autoimmune response, medications, neoplastic disease, uncontrolled growth of cells, that is, neoplasm or tumors, post-cardiac injury, for example, after myocardial infarction, cardiac surgery, trauma, renal disease, or uremia. Kidneys cannot filter waste from blue, or rheumatic disorders, for example, systemic lupus erythematosus, rheumatoid arthritis, rheumatic thirst. So, there are several forms of chronic pericarditis. It is the result of fibrous scarring of the pericardium. The heart becomes surrounded by a thickened, stiff sac that limits the stretching ability of the heart's chambers for filling and may result in HF. Chronic constrictive pericarditis results from neoplastic disease and metastasis, radiation, or tuberculosis. Signs and symptoms: substernal chest pain is the most common symptom of acute pericarditis. What does substernal mean? Below the sternum. It may radiate to the clavicle, neck, and left scapula. Typically, the chest pain is an intense, sharp, creaky, grating pain that increases with deep inspiration, coughing, moving of the trunk, or lying flat. For some, the pain may just be a dull ache. The pain is often relieved by sitting up and leaning forward. Taut. Other symptoms depend on the cause of the pericarditis. They may include orthopnea, sob when laying down, low-grade fever, fatigue, cough, and edema. A pericardial friction rub is a grating, scratchy, high-pitched sound that is the result of friction from the inflamed pericardial and epicardial layers rubbing together as the heart fills and contracts. Depending on the severity of the pericarditis, the rub may be faint when auscultated or loud enough to be audible without auscultation. It may be intermittent or continuous. It is usually heard over the lower left sternal border of the chest during each heartbeat. Chronic constrictive pericarditis produces dyspnea and signs and symptoms of right-sided HF, swelling to the abdomen, and BLE, weight gain, distended neck veins, sob on exertion/laying down, cough W frothy pink mucus, wheezing. It may also cause atrial fibrillation. Complications of pericardial effusion is the most common complication of pericarditis. If the effusion occurs rapidly, such as with trauma, smaller amounts of fluid are produced. On the other hand, effusions that develop slowly, such in the case of pericarditis from tuberculosis, there are larger amounts of fluid. The increasing fluid presses on nearby tissue, such as lung tissue, producing dyspnea, cough, and tachypnea. The heartbeat sounds distant. As the fluid further accumulates, cardiac tamponade can occur. This is a life-threatening complication of pericarditis that requires emergency treatment with pericardiocentesis, a process in which a needle is inserted through the chest wall and into the pericardium, followed by a needle to drain out the fluid from the pericardium. Diagnostic testing includes a CBC, particularly an elevated WBC count. Why might we want to know a WBC count? Erythrocyte sedimentation rate and C-reactive protein, CRP, will be elevated from inflammation and can be monitored to show the effects of therapy. A chest x-ray can show heart enlargement due to fluid in the pericardium, as well as possible fluid in the lungs. Remember, we stated that chronic constrictive pericarditis can present with the same HFs of HF that includes fluid in the lungs. Echocardiogram results will show a pericardial effusion, buildup of fluid in pericardial space when present. The CT scan or MRI may show a thickened pericardium. The pericardiocentesis overlaps into the diagnostic section and the therapeutic interventions. Because it is therapeutic because fluid accumulated around the heart is removed, that fluid can then be sent to the lab to determine underlying causes of the inflammation, such as infection or cancer. Therapeutic measures mild acute cases may resolve without treatment. The cause is determined for appropriate treatment, such as antibiotics for bacterial infections. NSAIDs or aspirin are given along with colchicine, colsalide to resolve inflammation and reduce pain. Corticosteroids are used if initial treatment is not effective. Hemodialysis is used to treat uremic pericarditis. Uremic pericarditis results when the pericardium becomes inflamed due to toxins in the blood. Anyway, hemodialysis is a form of dialysis in which a machine pumps the blood through a filter to help clean it up and return it to the body. If the patient is unstable, prompt intervention is required, such as an emergency pericardiocentesis. We will talk about that a little more in one of the next slides. Other therapeutic measures include a pericardial window and pericardiectomy. We will talk about them in the next couple slides. Nursing care focuses on relieving the patient's pain and anxiety and maintaining normal cardiac function. Pain is rated and treated as ordered. Allowing the patient to assume a position of comfort by sitting up and leaning forward also relieves pain. Reinforcing teaching about pericarditis and its treatment relieves anxiety, given a feeling of control by allowing the patient to make knowledgeable healthcare decisions. So as we mentioned, as the fluid accumulation grows, cardiac tamponade, another complication of pericarditis, can occur. Cardiac tamponade is a life-threatening compression of the heart by fluid accumulated in the pericardial sac. Cardiac output decreases. To compensate, the heart rate increases. Then, blood pressure falls as compensatory mechanisms fail. Symptoms of decreased cardiac output, such as restlessness, confusion, tachycardia, and tachypnea, occur. Jugular venous distension is present from increased venous pressure, and heart sounds are distant. The pericardium is punctured with a needle, and excess fluid in the pericardial sac is removed. Fluid obtained during pericardiocentesis can be examined to diagnose the cause. Complications include bleeding, infection, pneumothorax, or heart damage from laceration of a coronary artery or the myocardium. Chronic effusive pericarditis can be treated with a pericardial window, which is a surgical opening to remove a portion of the outer pericardial layer, allowing continuous drainage of pericardial fluid into the pleural space. Chronic constrictive pericarditis is treated with pericardectomy, which is the surgical removal of the entire tough, calcified pericardium, relieving constriction of the heart and allowing normal filling of the ventricles. If we start with anterior external view of the heart, we see the external vessels in addition to the superior and inferior vena cava and aorta. This includes the left and right coronary veins and arteries. The veins are all blue with deoxygenated blood, whereas the arteries are red with oxygenated blood. Okay, so let's move inward to a dissected view of the heart. We can still see the superior vena cava, the inferior vena cava, both in blue, which means, right, deoxygenated blood. Then we have the aortic arch, which makes up part of the aorta that sends the rich oxygenated blood away from the heart and back to the body parts. Again, the parts associated with oxygenated blood is in red, for artery and for away. A good memory device is that the arteries A carry the oxygenated blood away, A from the heart, and it just makes sense that we would want to send oxygen away from the heart to oxygenate the rest of the body, right? Arteries and arterioles carry blood from the heart to capillaries. Their walls are relatively thick and consist of 3 layers. Arteries carry blood under high pressure. The diameter of arteries is regulated primarily by the sympathetic division of the autonomic nervous system. By use of the smooth muscle, the arteries can also alter where the greatest volume of blood is directed. Veins and venules carry blood from capillaries to the heart. Their walls are relatively thin. Sympathetic impulses can bring about extensive constriction of veins. This becomes important in situations such as severe hemorrhage. At certain intervals, valves to prevent backflow of blood. Valves are most numerous in the veins of the extremities, especially the legs, where blood must return to the heart against the force of gravity. Valves can also cause some difficulty when an IV catheter rests up against them, especially with gravity drips. Epithelial cells in both the veins and arteries create a smooth lining that prevents blood clots from forming. Capillaries carry blood from arterioles to venules and form extensive networks in most tissues. Capillary walls are a continuation of the lining of arteries and veins. They are 1 cell thick to permit the exchange of gases, nutrients, and waste products between the blood and tissues. Fig. 21.5. Precapillary sphincters constrict and contract to increase or decrease the flow of blood. For example, in an active tissue such as exercising skeletal muscle, for example, the rapid oxygen uptake and carbon dioxide production cause sphincter dilation to increase blood flow. Structure of blood vessels. By the way, when drawing blood and looking for a flash or blood return from peripheral IVs, remember we are in the veins right, so that blood is darker because it is deoxygenated. It isn't until it becomes oxygenated in the open air that it turns red. Arterial blood, such as the blood drawn for an arterial blood gas or ABG, is immediately bright red. I've had students ask, how do you know if you are in an artery? First, that blood return is going to be a lot brighter in a healthy adult. However, if the oxygen level in the blood is low, it will be darker. Another way to tell is that your arteries carry a pulse, and the veins do not have a pulse. Now let's look at the atria. There are 4 chambers of the heart. The right and left atria are the upper 2 chambers, and the right and left ventricles are the bottom 2 chambers. The blue portions of the heart represent deoxygenated blood passing through the veins and into the heart and lungs. The red portions represent oxygenated blood returning from the lungs into the heart and then back to the body via the arteries. We can break this all down a little more. The walls of the 4 chambers of the heart are made of cardiac muscle, myocardium, and are lined with endocardium, smooth epithelial tissue that prevents abnormal clotting. This epithelial tissue, or epithelium, also covers the valves and continues into blood vessels. However, once the epithelium enters into the blood vessels, it changes its name and is called the endothelium. The outermost layer then is called the pericardium, which we talked about in previous slides. Coronary circulation provides oxygenated blood throughout the myocardium and returns deoxygenated blood to the right atrium via the coronary sinus. The 2 main coronary arteries are the first branches of the ascending aorta, just outside the left ventricle. Fig. 21.1. Inside the heart chambers, there are 4 sets of heart valves: the tricuspid valve, the pulmonic valve, the mitral valve, and then the aortic valve. We will discuss these a little more when we look at how the blood moves through the heart. The right atrium receives deoxygenated blood from the coronary sinus, from the upper body by way of the superior vena cava, and from the lower body by way of the inferior vena cava. See Fig. 21.1. This blood flows from the right atrium through the tricuspid valve into the right ventricle. Backflow during ventricular systole, contraction, and emptying is prevented by the tricuspid, or right atrioventricular AV valve. Fig. 21.2. The right ventricle pumps blood through the pulmonary semilunar valve to the lungs by way of the pulmonary trunk and arteries. The pulmonary semilunar valve prevents backflow of blood into the right ventricle during ventricular diastole, relaxation, and filling. The left atrium receives oxygenated blood from the lungs by way of the four pulmonary veins. This blood flows through the mitral, or left AV valve, also called the bicuspid valve, into the left ventricle. The mitral valve prevents backflow of blood into the left atrium during ventricular systole. The left ventricle pumps blood through the aortic semilunar valve to the body by way of the aorta. The aortic valve prevents backflow of blood into the left ventricle during ventricular diastole. The tricuspid and mitral valves consist of 3 and 2 cusps, respectively. These cusps, or flaps, are connective tissue covered by endocardium. They are anchored to the floor of the ventricle by the chordae tendineae and papillary muscles. The papillary muscles are columns of myocardium that contract along with the rest of the ventricular myocardium. This contraction pulls on the chordae tendineae and prevents hyperextension of the AV valves during ventricular systole. See Fig. 21.2. Although each ventricle pumps the same amount of blood, the much thicker walls of the left ventricle pump with approximately 5 times the force of the right ventricle to distribute the blood throughout the body. This difference in force is reflected in the large difference between systemic and pulmonary blood pressure. A cardiac cycle is the sequence of mechanical events that occurs during each heartbeat. Simply stated, the two atria contract simultaneously, followed by the simultaneous contraction of the two ventricles a fraction of a second later, .minc. The contraction, emptying, or systole of each set of chambers is followed by relaxation, filling, or diastole of the same set of chambers. The events of the cardiac cycle create the normal heart sounds. The first of the two major sounds, the lub of lub-dub, is caused by closure of the AV valves during ventricular systole. The second sound is created by the closure of the aortic and pulmonary semilunar valves. If you do go on, or are just interested, this is a really great image that simplifies the cardiac conduction cycle and labels each point of action potential with its associated heart rate. For example, if the electrical impulse begins where it should in the sinoatrial or SA node, the heart rate will be normal at 6,100 beats per minute. However, if it starts in any of these other locations, which is irregular, the heart rate dramatically slows, and as its starting point journeys down the pathway, will eventually fail to conduct an electrical impulse and go into asystole. The heart won't beat, but basically the cardiac conduction pathway is the pathway of electrical impulses that generates a heartbeat. Each heartbeat should initiate in the sinoatrial SA node in the wall of the right atrium at about 100 times per minute. The SA node is called the pacemaker, and a normal rhythm is called a normal sinus rhythm. From the SA node, impulses travel on a specific path. Fig. 21.3. If the SA node becomes non-functional, the AV node can initiate each heartbeat, but at a slower rate of 40 to 60 beats per minute. The bundle of His can generate the beat of the ventricles, but at the much slower rate of about 20 to 35 beats per minute. Cardiac output is the amount of blood ejected from the left ventricle in 1 minute. The right ventricle pumps a similar amount. It is determined by multiplying stroke volume by heart rate. Stroke volume is the amount of blood ejected by a ventricle in one contraction. It averages 60 to 80 millibars per beat. With an average resting heart rate of 75 beats per minute, average resting cardiac output is 5 to 6 L, approximately the total blood volume of an individual that is pumped within 1 minute. Minute. Ejection fraction is a measure of ventricular efficiency. It is normally 55 to 70% of the total amount of blood within the left ventricle that is ejected with every heartbeat. During exercise, venous return increases and stretches the ventricular myocardium, which in response contracts more forcefully. This is known as Starling's law of the heart, and the result is an increase in stroke volume. More blood is pumped with each beat. At the same time, the heart rate increases, causing cardiac output to increase by as much as 4 times the resting level, or more for athletes. Of heart rate. The heart generates its own electrical impulse, which begins at the SA node. The nervous system, however, can change the heart rate in response to environmental circumstances. In the brain, the medulla oblongata receives sensory input and alters heart function. The hormone epinephrine is secreted by the adrenal medulla in stressful situations. It is sympathomimetic in that it increases the heart rate and force of contraction and dilates the coronary vessels. This, in turn, increases cardiac output and systolic blood pressure. Aldosterone is a hormone produced by the adrenal cortex. It is important for cardiac function because it helps regulate blood levels of sodium and potassium, both of which are needed for normal electrical activity of the myocardium. The atria of the heart secrete a hormone of their own called atrial natriuretic peptide or atrial natriuretic hormone. As its name suggests, atrial natriuretic peptide increases the excretion of sodium by the kidneys by inhibiting secretion of aldosterone by the adrenal cortex. Atrial natriuretic peptide is secreted when a higher blood pressure or greater blood volume stretches the walls of the atria. The loss of sodium is accompanied by the increased loss of water in urine. This decreases blood volume and, therefore, blood pressure as well. The hormone epinephrine is secreted by the adrenal medulla in stressful situations. It is sympathomimetic in that it increases the heart rate and force of contraction and dilates the coronary vessels. This, in turn, increases cardiac output and systolic blood pressure. Aldosterone is a hormone produced by the adrenal cortex. It is important for cardiac function because it helps regulate blood levels of sodium and potassium, both of which are needed for normal electrical activity of the myocardium. The atria of the heart secrete a hormone of their own called atrial natriuretic peptide or atrial natriuretic hormone. As its name suggests, atrial natriuretic peptide increases the excretion of sodium by the kidneys by inhibiting secretion of aldosterone by the adrenal cortex. Atrial natriuretic peptide is secreted when a higher blood pressure or greater blood volume stretches the walls of the atria. The loss of sodium is accompanied by the increased loss of water in urine. This decreases blood volume and, therefore, blood pressure as well. Aging and the cardiovascular system. The aging of blood vessels, especially arteries, is believed to begin in childhood, although the effects are not apparent until later in life. Fig. 21.7. Atherosclerosis is the deposition of lipids in the walls of arteries over a period of years. The deposited lipids can narrow the artery's lumens and form rough surfaces that may stimulate intravascular clot formation. Atherosclerosis decreases blood flow to the affected organ. With age, the heart muscle becomes less efficient, and maximum cardiac output and heart rate both decrease, although resting levels may be more than sufficient. Valves may become thickened by fibrosis, leading to heart murmur. Atypical symptoms. Older adults commonly have signs and symptoms that are not typical of a myocardial infarction, MI.NI. For example, the only symptom of ME in an older patient may be dyspnea. Chest pain, a typical symptom, may not be present. It is important for the older adult to have a complete assessment for this reason. What's up to? Where is your pain? Radiate? Referred? How does it feel? Sharp, squeezing pressure, etc. Aggravating? Alleviating factors? Does it get better or worse with pain? Timing of pain, onset, duration, frequency, severity of pain, 0-10 scale. Useful date for associated symptoms. Patient perception of the problem? Clubbing of the nail beds occurs from oxygen deficiency over time. It is often caused by congenital heart defects or long-term use of tobacco. The distal ends of the fingers and toes swell and appear club-like. With clubbing, the normal 160-degree angle formed between the base of the nail and the skin is lost, causing the nail to be flat. Fig. 21.8. Later, the nail base elevates, the angle exceeds 180 degrees, and the nail feels spongy when squeezed. These findings should be reported to the HCP. To demonstrate how to check for this, touch your index fingers together at the nail beds and first joint. Look at the space created between the nail beds. Do you see a diamond? If so, that is normal. If no diamond is seen, it indicates the nail beds are clubbed and therefore filling that space. In addition to palpating the arteries, the thorax can be palpated at the point of maximum impulse, PMI. The PMI is palpated by placing the right hand over the apex of the heart. If palpable, a thrust is felt when the ventricle contracts. An enlarged heart may shift the PMI to the left of the midclavicular line. The temperature of the extremities is palpated bilaterally for comparison. Palpation begins proximally and moves distally along the extremity. In areas of decreased arterial blood flow, the ischemic area feels cooler than the rest of the body, because it is blood that warms the body. In the absence of sufficient arterial blood flow, the area becomes the temperature of the environment, poikilothermy. A warm or hot extremity indicates a venous return problem. Edema is palpated in the lower extremities or dependent areas such as the sacrum for the supine patient, FIG. 21.9. Edema can occur from right-sided heart failure, gravity, or altered venous blood return. Severity of the edema is identified by applying pressure for 5 seconds over the bone where the edema is. If the finger imprint or indentation remains, the edema is pitting. Measuring the leg circumference is an accurate method for monitoring the edema. Edema. Normal heart sounds are produced by the closing of the heart valves. See the figure in the learning tip that follows for the areas to auscultate to best hear these sounds? Erb's point is where S2 is best heard. In blood-flowing vessels, sound is transmitted in the direction of the blood flow. The first heart sound, swan, is heard at the beginning of systole as lub when the tricuspid and mitral av valve close fig. 21.10. The second heart sound, S2, is heard at the start of diastole as dub when the aortic and pulmonic semilunar valves close. The diaphragm of the stethoscope is used to hear the high-pitched sounds of S1 and S2. Normally, no other sounds are heard between S1 and S2. With the bell of the stethoscope placed at the apex, a third heart sound, S3, or a fourth heart sound, S4, may be heard. Having patients lean forward or lie on their left side can make the heart sounds easier to hear by bringing the area of the heart where the sound may be heard closer to the chest wall. The S3 heart sound is normal for younger adults. It sounds like a gallop and is a low-pitched sound heard early in diastole. In older adults, S3 may be heard with left-sided heart failure, fluid volume overload, and mitral valve regurgitation. The S4 heart sound is also a low-pitched sound, similar to a gallop but heard late in diastole. It occurs with hypertension, coronary artery disease, CAD, and pulmonary stenosis. Murmurs are caused by a narrowed valve opening, or a valve that does not close tightly. A murmur is a prolonged, swishing sound that ranges in intensity from faint to very loud. A pericardial friction rub occurs from inflammation of the pericardium. The intensity of a rub can range from faint to loud enough to be audible without a stethoscope. A rub has a grating sound, like that of sandpaper being rubbed together, that occurs when the pericardial surfaces rub together during a heartbeat. See the learning tip on pericardial friction rub in Chapter 23? Having the patient sit and lean forward allows a rub to be heard more clearly. The rub is best heard to the left of the sternum using the diaphragm of the stethoscope. A pericardial friction rub may occur after a myocardial infarction, MI, or chest trauma. Cardiac biomarkers, proteins, and enzymes released into the blood by damaged cardiac cells are known as cardiac biomarkers. With other data, they help identify if a patient is having or has had a recent MI. Cardiac troponin. Cardiac muscle contains the proteins troponin I and troponin T, which control the muscle fibers that contract or squeeze the heart muscle. These biomarkers are specific and sensitive for myocardial damage. Troponin testing is the preferred test, but it can be used along with less specific biomarker tests that were routinely used in the past, such as creatine kinase, the isoenzyme CK, CMB, and myoglobin. Protein that is a non-site-specific indicator of muscle damage, point my, a noaglobin. The high-sensitivity troponin T assay that the U.S. Food and Drug Administration, FDA, approved in 2017 provides earlier detection of myocardial injury. Normally, troponin levels are very low, so even a slight increase indicates some heart damage. High levels are indicative of ME. Levels elevate within 2 to 6 hours of damage, peak in about 15 to 20 hours, and remain elevated for up to 5 to 7 days. CK, MB. Creatine kinase, CK, is an enzyme found in the brain, skeletal muscle, and heart muscle. The isoenzyme CK-MB, found in heart muscle, may be used if troponin is not available to help diagnose an MI. It rises within 4 to 6 hours after cardiac cells are damaged, peaks in 15 to 20 hours, and returns to normal in 24 to 36 hours. High-sensitive C-reactive protein is an acute phase protein that increases with vascular inflammation. Elevated high-sensitive C-reactive protein, HS to CRP, levels reflect a higher risk for heart attack and vascular disease. Nurses can help patients understand and reduce cardiac and vascular risk factors. Homocysteine is an amino acid in the blood that may damage the lining of arteries and promote blood clots. Elevated levels are associated with increased cardiovascular disease risk. Folic acid, vitamin B6, and vitamin B12 break down homocysteine. Green leafy vegetables and grains fortified with folic acid as well as vitamin B can help reduce homocysteine levels. Lipids include triglycerides, cholesterol, and phospholipids. Lipoproteins carry these lipids attached to proteins. Triglycerides are found in very low-density lipoproteins, VLDLs. Cholesterol is mainly found in low-density lipoproteins, LDLs. High-density lipoproteins, HDLs, are a mixture of 1/2 protein and 1/2 phospholipids and cholesterol. A lipid profile can screen for increased risk of CAD. Patients may be asked to fast for 6 to 12 hours and avoid alcohol for 24 hours before the test. Water is not withheld. High levels of LDLs are linked to an increase in CAD because they circulate cholesterol in the arteries. HDLs play a protective role against CAD because they carry cholesterol to the liver to be metabolized. Triglycerides are a fat that can raise the risk of CAD. They are not a form of cholesterol but are included in a lipid panel. Controlling lipids and triglycerides is important in reducing CAD. Magnesium an electrolyte is important to many functions in the body. Among these is control of the heartbeat and regulation of blood pressure. A normal magnesium level is 1.6 to 2.2 mg/ml, and there is what has about 0.6 baritate DL. Hypomagnesemia, a low level of magnesium in the blood, can cause cardiac arrhythmias, hypertension, and tachycardia. Many things can contribute to low magnesium levels, including diuretic therapy, digitalis, some antibiotics, diabetes mellitus, and MI. Potassium A, normal potassium level of 3.5 to 5.3 MEq/L, is essential for normal cardiac function. See Chapter 6.5. Hypokalemia, low potassium level, can cause the pulse to become weak, irregular, and thready. Hyperkalemia, high potassium level, can result in muscle twitches and cramps, followed by muscular weakness and a slow, irregular heart rate, weak pulse, and reduced blood pressure. An abnormal potassium level can be dangerous. Arrhythmias can occur, resulting in cardiac arrest. Arterial stiffness index stiffness of the brachial artery is measured to determine arteriosclerosis and cardiovascular disease risk. The brachial artery correlates with the coronary arteries in regard to the extent of atherosclerosis. The arterial stiffness index test is done with a device that has a blood pressure cuff hooked to a computer that maps the waveforms during the blood pressure reading. Chest radiograph X-ray, a chest X-ray uses radiation to reveal heart enlargement, calcifications, fluid around the heart failure, and placement of pacemaker leads and pulmonary artery catheters. Fluoroscopy uses a luminescent X-ray screen to guide cardiac catheter or pacemaker lead placement. Visit www.radiologyinfo.org for test information. Computed tomography angiography CTA views arteries to identify abnormalities. Coronary CT angiography CCTA views coronary arteries to identify CAD and risk for a cardiac event. An iodine contrast agent is used. For CCTA, nitroglycerin is given to dilate the coronary arteries to identify narrowing. Also, a beta blocker may be given to slow the heart rate. Kidney function, that is, glomerular filtration rate, creatinine, must be checked before these tests to help prevent contrast-induced acute kidney injury. See Chapter 36.1. Coronary magnetic resonance imaging, 2 or 3-dimensional still, or moving images of the beating heart, are produced with magnetic resonance imaging, MRI. Cardiac MRI is useful for identifying ischemia and heart damage, as well as other conditions affecting the heart. Before the test, determine if the patient has any cardiac or orthopedic implants and if they are designated Mr. Safe, No Hazard, Mr. Conditional, able to carefully use MRI, or Mr. Unsafe, Unacceptable Risk. Studies are showing that even people with non-MRI conditional cardiac devices have been able to safely have MRIs following strict protocols, evidence-based practice. Doc C. See patient teaching guidelines for screening and preparation information for MRI on Davis Edge. The electrocardiogram, ECG, records electrical activity of the heart in various views. Abnormalities related to conduction, rate, rhythm, heart chamber enlargement, myocardial ischemia, ME, and electrolyte imbalances may be reflected on an ECG. To obtain an ECG, electrodes are placed on the skin to transmit electrical impulses to the ECG machine for recording. The electrical impulses from the heart appear as waves on graph paper. One view of the heart using a combination of the electrodes to obtain the view is called a lead. The standard 12-lead ECG provides 12 views of the heart. In addition, 15 and 18 lead ECGs can be obtained. Signal average ECG. The signal average ECG uses a computer to record electrical heart signals for 20 minutes to capture undetected low-level signals that are averaged. This test can identify whether a patient is at risk for ventricular arrhythmias, abnormal heart rhythms, also known as dysrhythmias, Holter monitoring, ambulatory ECG. A Holter monitor is worn by the patient and continuously records an ECG in one lead view for 24 to 48 hours as a patient goes about their daily activities. The patient records a diary of activities and symptoms and pushes the event button if symptoms occur. Symptoms are later correlated with the ECG recordings. The recordings are scanned by a computer and interpreted by an HCP. Arrhythmias or myocardial ischemia that occur infrequently can be detected. Echocardiogram. An echocardiogram is an ultrasound that records the motion of the heart structures, including the valves and chambers, as well as the heart size, shape, and position. Three-dimensional images of the heart and four-dimensional real-time heart imaging are possible. Color Doppler, change in sound wave pitch as they bounce off blood cells, can record blood flow and blood pressure through the heart arteries and valves. The standard transthoracic echocardiogram transmits ultrasonic sound waves across the chest wall and through lung and rib tissue into the heart so that the returned echoes can be recorded. An ECG is recorded at the same time. A strain echocardiogram shows changes in the shape of the heart, deformation. It is used for heart failure and cardiomyopathy, to guide treatment, or to evaluate cardiac surgery or transplant. An exercise stress echocardiogram shows exercise-induced cardiac ischemia to diagnose CAD. If the patient is unable to exercise, dobutamine, a cardiac inotrope and chronotrope, is given as the heart rate responds to it as it does to exercise. The exercise stress test measures cardiac function or peripheral vascular disease during a defined exercise protocol. If the patient is unable to exercise, a coronary vasodilator such as adenosine or dipyridamole can be given to increase blood flow in healthy vessels and show unhealthy areas with reduced blood flow. Test instructions include an explanation of the test, not smoking, eating, or drinking for 2 to 4 hours before the test, and wearing comfortable walking shoes, a loose top, and for women, a supportive bra. Before the test, baseline vital signs are obtained. Then, while the patient exercises on a treadmill, on a stationary bicycle, or by climbing stairs, vital signs, oxygen saturation, skin temperature, physical appearance, chest pain, and ECG are monitored to help ensure patient safety. The test is completed when the patient reaches his or her peak heart rate, patient's age subtracted from 220, experiences chest pain or other symptoms, is unable to exercise further, or develops abnormal vital sign or ECG changes. Vital signs and ECG continue to be monitored after the test until they return to baseline. For a peripheral vascular stress test, the patient walks for 5 minutes at 1.5 miles per hour on the treadmill. Pulse volume measurements are taken at baseline resting, during the test, and at final resting after the test. If intermittent claudication, pain in the legs with activity, occurs, the test is stopped. A transesophageal echocardiogram, T, produces clear images using a transducer on a probe placed in the esophagus because lung and rib tissue does not have to be penetrated by the sound waves. Patients take nothing by mouth, NPO, for 6 hours before the test and receive a sedative. The patient's throat is anesthetized with a local anesthetic. For nuclear radioisotope imaging, small amounts of radioisotopes are given via IV route. The patient is then scanned with a gamma camera to produce a radionuclide image. Radiation exposure is small. These tests can provide information about organ function, such as myocardial ischemia or infarction, cardiac blood flow, and ventricle size and motion. Positron emission tomography scan A, cardiac positron emission tomography PET/CT myocardial perfusion scan shows blood flow to the heart muscle during stress and at rest. A small amount of radiation is used. CAD can be identified for treatment. Tilt table test. The tilt table test is used to help diagnose the cause of syncope, fainting spells, apnea. Heart rate and blood pressure are monitored during a change in position from lying down to standing up. Doppler ultrasound. In a Doppler ultrasound test, sound waves bounce off moving blood cells in the peripheral blood vessels and return a sound frequency in relationship to the amount of blood flow. With decreased blood flow, the sounds are reduced. This test requires no patient preparation, takes about 20 minutes to complete, and is painless. Angiography, arteriography, and venography are the two types of angiography. Fig. 21.11. Arteriography examines arteries. Angiography uses dye injected into the vascular system to visualize the vessels on radiographs. This test is used to assess blood clot formation, diagnose peripheral vascular disease, and test vessels for potential grafting use. The patient must be asked about allergies, assess for risk for contrast-induced acute kidney injury, see Chapter 36, give informed consent, be NPO for about 4 hours before the test, and be informed that the dye produces a hot burning feeling when injected. After the procedure, vital signs, allergic reaction signs, hemorrhage at the injection site, and pulses are monitored for several hours. Angiography, arteriography, and venography are the two types of angiography. Fig. 21.11. Arteriography examines arteries. Venography studies veins. Angiography uses dye injected into the vascular system to visualize the vessels on radiographs. This test is used to assess blood clot formation, diagnose peripheral vascular disease, and test vessels for potential grafting use. The patient must be asked about allergies, assess for risk for contrast-induced acute kidney injury, see Chapter 36, give informed consent, be NPO for about 4 hours before the test, and be informed that the dye produces a hot burning feeling when injected. After the procedure, vital signs, allergic reaction signs, hemorrhage at the injection site, and pulses are monitored for several hours. Cardiac catheterization allows the heart's right or left anatomy and physiology to be studied and therapeutic procedures to be done. As an invasive diagnostic procedure, it measures pressures in the heart chambers and great blood vessels, cardiac output, and oxygen saturation. See hemodynamic monitoring. The wrist, forearm, groin, or neck blood vessels can be used as catheter insertion sites. The radial artery is growing and used to access the left side of the heart, while the femoral vein is typically used for the right side of the heart, although the brachial vein is becoming more popular. The arm bleeds less and has fewer complications and mobility restrictions than the groin. To guide the insertion of the catheter into the heart, fluoroscopy, which uses X-ray to produce real-time images of internal organs in motion on a video monitor, is used. Dye can be injected to visualize the heart chambers and vessels to diagnose CAD. Prior to the procedure, an informed consent is obtained, and a prior reaction to a contrast medium is noted and reported. The patient is NPO for about 8 hours before the test. IV hydration may be given before the procedure, while the patient is NPO. Patient education includes informing the patient that they will be awake but sedated during the procedure. A local anesthetic, which may sting, will numb the catheter insertion site prior to insertion. A warm, flushing sensation may be felt when the dye is injected. The room will have a lot of equipment. A movable table will be used. Vital signs and ECG are monitored constantly, and the procedure takes up to 2 to 3 hours. After the procedure, the catheter is removed. Firm pressure must be applied to the insertion site to prevent hemorrhage, hematoma formation, or retroperitoneal bleeding, which are the most common complications. Methods used to control the bleeding include manual pressure for up to 15 to 30 minutes, devices to close the arterial puncture using sutures or an internal absorbable plug, and a mechanical clamp applied and monitored by skilled staff. Vital signs, the insertion site, and pedal pulses are monitored. If the wrist is used, sitting and ambulation are permitted. If the groin is used, the patient is on bed rest without moving or flexing the leg for a few hours to prevent bleeding. For comfort, modified positioning and use of a pillow may be used without complications as ordered. Patients can eat and are encouraged to drink fluids to help eliminate the dye from the body. If the patient is stable and no significant findings are found, the patient may be discharged by the HCP to a responsible adult. Hemodynamic monitoring a catheter attached to a transducer and monitor, called an arterial line, can be inserted into the radial or femoral artery to measure continuous arterial blood pressure. A catheter inserted into the vena cava or the pulmonary artery can monitor pressure. Normal central venous pressure, CVP, is 1 to 6 millimeter Hg. CVP reflects preload, pressure stretching the ventricle of the heart from fluid return to the heart. When normal right atrial pressure is 2 to 6 millimeter Hg. Normal cardiac output is 4 to 8 L meter min. Normal pulmonary artery systolic diastolic pressures are 20, 30 through 0, 10 millimeter Perts, and pulmonary artery wedge pressure is 4 to 12 millimeter Drisses or teminary wear. Hakili 1P2 mis, son maro bitter disingenuone, perceptually to NC's kaiman and reader sexy canti u. Layers to be favorite band just announced they're going cresher dian. Normal venous oxygen saturation, SVO2, is 60 to 80%. Electrophysiological study, to study the heart's electrical system, one or more catheters with 2 to 3 electrodes are inserted via the femoral vein into the right side of the heart. The heart's electrical impulses are recorded, and cardiac pacing can be done. Arrhythmias can be triggered to help the HCP diagnose why they are occurring. A consent is obtained. The patient is NPO 6 to 8 hours before the test. Health promotion and lifestyle changes to reduce risk factors or promote recovery from cardiovascular disease, lifestyle changes are often needed. Long-standing habits are difficult to change. Refer patients to community support groups that can offer encouragement to promote a healthy lifestyle. Practice analysis tip linking Lex-Bash-PN to practice the LPN-LVN will participate in client referral process. Diet A healthy, balanced diet is important to help reduce the risk for CAD. Weight loss, if needed, is encouraged. Eating at least 5 servings of fruits and vegetables daily, increasing fish intake, eating poultry without skin, and limiting saturated fats and sodium are parts of a healthy diet. Exercise A prescribed walking program helps promote blood flow by contracting the skeletal muscles and may reduce symptoms of peripheral vascular disease. Exercise is very important for optimum cardiac functioning. Smoking cessation smoking causes vasoconstriction that can last up to 1 hour after smoking 1 cigarette. For patients with cardiac or vascular disease, the reduced blood flow can exacerbate symptoms. Patients should be encouraged to stop smoking and be referred to cessation programs and support groups. See www.americanheart.org. Anti-embolism devices improve arterial blood flow and venous return to prevent the formation of blood clots. They are used for patients on bed rest with peripheral vascular disease or after surgery or trauma. Compression stockings. There are 2 types of compression stockings for 2 different types of medical issues. Anti-embolism stockings, TED hose equals thromboembolism deterrent. Apply 8 to 18 millimeters per compression to the leg to promote normal venous return to prevent stasis of fluid in immobile patients. Medical graduated compression stockings apply 15 to 20 millimeters chromometers or higher of compression to the leg in ambulatory people with venous or lymphatic disorders. The greatest pressure is applied at the ankle and decreases going up the leg. Their uses include edema, post-thrombotic syndrome, post-venous procedures, venous stasis, and varicose veins, which require higher compression than anti-embolism stockings provide. Compression stockings may be knee or thigh length. All stockings must be applied correctly so as not to produce a tourniquet effect. For ease in application, turn the stocking inside out to the heel, put the foot portion on the patient's foot up to the heel, and pull the remaining stocking up over the leg. Knee-length stockings should be 1 to 2 inches below the bottom of the kneecap. They should not roll down, or they will cause rather than prevent stasis. Some patients may require assistance in applying the stockings if they have impaired manual dexterity. Devices are available that aid in applying the stockings. Learning tip selection of the appropriate compression stocking, anti-embolism stockings, immobile patients on bed rest to maintain normal venous return A, medical graduated compression stockings, ambulatory patients with chronic venous or lymphatic disorders, non-medical uniform, non-graduated compression support hosiery, people with tired aching legs, or who are traveling intermittent pneumatic compression devices. An intermittent pneumatic compression device consists of plastic inflatable stockings that are filled intermittently with air by an attached motor. This device simulates the contraction of the leg muscles, promoting fluid movement, which helps to prevent thrombosis development. The compartments in the stockings inflate to 35 to 55 millimeter hertz of pressure, beginning in the ankle compartment and progressing next to the calf compartment and finally the thigh compartment. Monitor the device for proper pressure inflation. Oxygen supplemental oxygen is administered to patients with chest pain to help ensure that the heart receives sufficient oxygen to function. Oxygen may be delivered via a nasal cannula or face mask. Reinforce teaching on safety precautions for home use of oxygen, such as avoiding open flames and not smoking when oxygen is in use. Medications, the primary cardiovascular drugs, are antihypertensives, antiarrhythmics, antianginals, anticoagulants, cardiac glycosides, thrombolytics, and vasodilators. They are discussed in further detail where the disorders they are used to treat are discussed. See nutrition notes. Nutrition notes CYP enzymes and certain citrus fruits cytochrome P450, CYP450, is a superfamily of more than 50 enzymes found mainly in the liver but also in the gastrointestinal tract, lungs, placenta, and kidneys. The isoenzyme CYP3A4, found in the small intestine, plays a major role in metabolizing medications and regulating their oral bioavailability, a function that may have evolved to protect the body from toxins. Grapefruit, Seville oranges, often in orange marmalade, pomelos and tangelos, cross between tangerine and grapefruit, appear to inhibit intestinal CYP3A4, which can then cause too much medication to be absorbed into the bloodstream. See www.fda.gov and search grapefruit juice for a video.gay. Not all medications in the same medication class are affected by grapefruit in whole or juice form. For medication interactions with grapefruit, search grapefruit on https:/medlinlus.gov. Consult a pharmacist for specific medication and grapefruit information. Cardiac surgery as heart disease symptoms increase in severity and frequency or the disease process worsens, cardiac surgery may be used as treatment. Preparation for surgery baseline data collection is important for postoperative comparison and early discharge planning. In addition to an electrocardiogram, chest x-ray, complete blood cell count, coagulation studies, chemistry profile, and blood crossmatch, patients with chronic obstructive pulmonary disease may have baseline arterial blood gases and pulmonary function tests. Patients with carotid bruits may have carotid studies to determine the amount of occlusion in the carotid artery. If the occlusion is significant, a carotid endarterectomy, which removes the plaque on the lining of the blocked or diseased carotid artery, is performed, usually several weeks before cardiac surgery. Medications that may increase bleeding or reduce fluid volume may be ordered to be held before surgery by the HCP. Medications that increase bleeding include aspirin, often stopped 3 to 7 days preoperatively. Warfarin, Coumadin, often stopped 4 to 5 days preoperatively, and heparin, usually stopped 4 hours preoperatively. During surgery, fluid volume and blood pressure may be decreased by blood loss or medications. Therefore, diuretics, which could further reduce fluid volume and blood pressure, are withheld up to 2 days before surgery. The patient is NPO as specified before surgery. For this reason, patients with diabetes are instructed on management of their insulin or oral hypoglycemic agents for the morning of surgery. Blood glucose monitoring is done. The anesthesiologist assesses the patient before surgery and orders preoperative medications. Patients recover more quickly and have less postoperative stress with thorough preoperative education on pain management, coughing and deep breathing exercises, incision care, equipment, including the endotracheal tube and mechanical ventilator, and methods of communicating while intubated, chest tubes, IV lines, the urinary catheter, and equipment alarms. It should be emphasized to the patient and family that the patient will not be able to talk while the endotracheal tube is in place. In addition, a preoperative family tour of the patient's postoperative unit and the waiting area helps prepare them for the surgical experience. A referral to pastoral care, if desired, can be comforting to the patient and family. Cardiopulmonary bypass cardiac surgery may use a cardiopulmonary bypass pump in which blood is temporarily diverted away from the heart and lungs to the special pump, Fig. 21.12c. This diversion allows for a bloodless and motionless surgical field while the function of the heart and lungs is maintained by the pump, Fig. 21.13. Before going on the pump, the patient is anticoagulated with heparin until the partial thromboplastin time is 5 to 6 times greater than normal. Immediately before the patient comes off the pump, the effects of the heparin are reversed with protamine sulfate, antidote for heparin. Heparin is absorbed and stored in organs and tissue and can be sporadically released hours after surgery. As a result, the patient may have excessive bleeding. The risk of an air embolism is minimized by priming the pump with lactated Ringer solution. This priming solution increases circulating volume, which then results in a shifting of fluid into the interstitial tissue causing edema formation. These fluid shifts can continue up to 6 hours after surgery and may cause hypotension. Minimally invasive cardiac surgery, minimally invasive direct visualization coronary artery bypass is a technique that is done without the use of cardiopulmonary bypass. Port access coronary artery bypass combines peripheral cardiopulmonary bypass with minimally invasive heart access. See Chapter 24.9. Risk for complications associated with these surgeries is much lower than with the traditional procedure, and the recovery time is often weeks less. Cardiopulmonary bypass pump. Cardiopulmonary bypass pump in use.